hi, welcome back. Welcome back to the MICD Symposium, and we hope you enjoyed your tea break. Did you enjoy your tea break, doctors?
Yeah.
Very well. And I hope you came back energized for more learning, right? Okay, so without any further delay, again, I am Dr. Says Sarah Tapping, and I will be your co-host and co-moderator together with Dr. Kim Fajardo for today's event. For our morning mid-lecture series, we will look into color matching and smile makeovers, which are both the talk of the town and meets the trend today. I've heard about 50 Shades of Grey. Have you heard about it? Okay, rings a bell, right? But I've never been more interested since I heard 50 Shades of White. We practice in a time where most of our patients look for a flawless, whiter, or brighter smile. But how white is white? How bright should the smile be? One of the markers of clinical cosmetic success is color matching. And today, we will look into achieving the perfect blend in anterior restorations. Just like a perfect blend of coffee, right? A perfect blend of coffee warms the heart. And a perfect blend in our restoration warms the dentist's heart. Yes, I am sure we are all looking forward to start, and I would like to take the honor to introduce our next lecturer. Let me just take the podium. Dr. Amit Gulati is a BDS and MDS from the University of Mumbai. He completed an advanced training in aesthetic, perioplastic surgery, implantology, and osseous regeneration at the University of Hamburg, Germany, and further expanded his expertise with advanced prosthodontic training under eminent clinicians in Germany. He trained in digital smile design, DSD, under Dr. Christian HoChiMinh, and was instrumental in introducing the Style Italiano concept in India through his academy. Dr. Amit has also had an extensive training in minimally invasive cosmetic dentistry, MICD concept, and treatment protocol in Malaysia, and is a certified MICD fellow and clinical trainer. He is a diplomat of the Indian Society of Oral Implantologists, a fellow of the International Congress of Oral Implantology, an associate fellow of World Clinical Laser Institute. He is also a key opinion leader to a number of global dental firms and involved with research and development of newer materials and techniques in aesthetic and implant dentistry. During 2 decades of aesthetic and implant practice, he has delivered numerous scientific presentations at various national and international conferences, in addition to conducting implant and aesthetic training programs in India and overseas. Apart from consulting for various aesthetic clinics in Mumbai, he also runs a busy practice with special focus on aesthetics, implantology, and oral rehabilitation. He's a passionate teacher and manages Synchronize, an academy established with other like-minded colleagues to train extensively on implant and aesthetic dentistry. Let us welcome on stage with a warm round of applause, Dr. Amit Gulati.
Thank you so much, Dr. Sess, for the kind introduction. A very good morning to all. And I guess coffee break. After the coffee break, everybody is fresh air. And thank you so much. Minimally, as in MICD Global Network and the Van Lang University and Sotadi and Shofu Dental for inviting me here. Sorry, I'll have to just change my. Yes. Thank you so much. Chào buổi sáng Việt Nam. This is my. Thank you so much for having me here in this beautiful country. This is my second time here in Vietnam, and every time I'm coming here, I'm loving this country, all the more. And I come from another beautiful country, India, and a warm namaste, okay, from all of us from India. I am from Mumbai, a city of dreams, what we call in India, and that's my practice in Mumbai. My practice goes by the name of Gums and Smiles, and that's my team. That's my team, and the lady on my left, okay, she's my wife. Okay, looks like okay, I'm the boss, but she is the actual boss in the clinic. Now, see, in the growing up years, when somebody used to ask me, what is the color of your teeth? I used to say, white. Okay, do we see the same trend now? Do we ask the kids and ask them, what is the color of the teeth? What do they say? White. But actually, does the teeth of the color of the teeth is actually white? Do we see the shades in dentistry as these monochromes of whites and grays? Or we see shades in dentistry or colors in dentistry, something like this, with all its vividness and colorfulness. Let's check this out. This is how we see colors in dentistry. Do we see, okay, the shades in monochromes, or we see colors, something like this. So the teeth are nowhere close to what we are being told as growing up here as a teeth are white. They are anything but white. Let's see another situation. See the vividness of colors, okay, in this particular situation. Now, before we try to understand the colors in dentistry, it's important for us to understand the science of color. Which color is this? Which color is this? Which red? Exactly. See, color is subjective. When we say red, it may not be just red. So, looking at the science of color, Albert once gave us the three dimensions of a color. He said color has three attributes or three dimensions, and that's what we understand in dentistry also: hue, chroma, and value. But these words or these these attributes, they sound so confusing. Let's try and understand what hue, chroma, and value actually mean. Let's understand what is hue. Can somebody give me this one, please? Now, hue is actually the color. Reds, yellows, blues, greens. The actual color component is what we understand as hue. Okay, so color means, the hue means the actual color. Now, what is chroma? The intensity of that particular color, say red, the intensity or the saturation is called as chroma. How do we understand saturation? Saturation means, or the intensity means, darker reds and lighter reds, right? For example, what you do is take a red poster color and start adding drops of water into it. So we are diluting this red color. Now, the more red is high chroma, the less red, which is diluted red, is less chroma. So that's how we understand the intensity or the saturation of that particular color. Let's see what is value. Now, value means the darkness or the lightness of that particular color. Isn't it same as chroma? That is intensity of color, the saturation of color. This is the darkness and the lightness of color. Aren't the same? Okay, let's do another experiment. Take same red color and to a part of it start adding whites, and to another part you start adding blacks. Okay, where you add whites, it starts to become lighter or brighter. It starts to become pinkish. And where you add blacks, it starts to become darker or it starts to becoming brownish. Right? So it's the lightness and the darkness. So it's not the dilution, it's the addition of the whites and the blacks. Where we have more whites, that means it has more value. Where we have more darks or the blacks, it has less value. Right? But how does this apply to dentistry? Let's understand this by getting the most commonly used tool for shade assessment in dentistry. That's the shade guide. This is what we use for shade assessment. And this is the most commonly used shade guide around the world, Vita Classical. Let's look at how we look at shades in Vita Classical. So when we look at hue, hue means the actual color. So in Vita Classical Shade Guide, the colors or the shade tabs, they are addressed as A, B, C, and D. These are the four hues what we look at in dentistry. Reddish brownish, reddish yellow, grayish, and reddish gray. So that stands for the hue of the teeth. Okay. Let's look at what is chroma. What is chroma? Chroma is the intensity or the saturation of that particular color or the hue. So when we look at A segment of the shade tabs, from A1 to A4, that is increasing chroma. You see, they are becoming darker. So that's the chroma in one specific segment of hue, that is A. Similarly, we have B, we have C, and we have D. Now when we look at chroma, see, chroma is an attribute of the inside of the tooth or the dentine or the core of the tooth. Let's look at what is value. Now value again is what? The lightness and the darkness. So here, if you look at in the same shade tab or in the same hue, that is A, the hue, the value is more in A1 and least in A4, right? But that becomes the same similar to like, chroma. So there has to be something, okay, which can differentiate value from chroma. Now, what is value? The value is the darkness or the lightness. Okay, so we don't see the value in terms of one particular hue. We want to see value as the entire shade guide. So value can be best brought about by making the image black and white. So when you convert the image to a black and white image or a desaturated image, you are able to see the whiteness and the darkness much better. Now, see, going back to the value, now value is an attribute of the enamel. Okay, so value is what, if you look at B1 is wider than A1, then B2, D2, A2. So this is how the value is. It's not restricted to one particular U segment. We'll understand this as we go forward in the talk. The value is an attribute of the surface of the tooth, as in the enamel. Let's look at this particular situation here. This clinical situation wherein this young lady we see, and she was kind of depressed, or she had almost stopped smiling because she used to feel her smile does not look good, her teeth are yellow, her teeth are dark. That's her own words. Okay, yellow and dark means the teeth are more saturated, they are high in chroma. Okay. And that's what we did. We did a round of whitening or bleaching for her, and then we did some minimally invasive smile makeover with dark veneers. She is on the top of the world. You can see the difference? Yes. She is smiling like crazy now. But the question here is, how critical was the shade selection in this particular situation? She wanted whiter teeth. Okay, we did bleaching for her. We picked up the brightest shade in a composite kitty, and we gave her this flashy, buoyancy, and vibrant smile. But was the shade determination very critical? Let's see another situation. How would the shade selection differ in this particular situation? How critical it would be for this particular situation? Actually, it would be very, very critical. The shade and the layering recipe. If our shade and the layering protocol is not right, what we end up is in a situation like this. If you see here the incisal edges, they appear a little too translucent. Appears that these edges, they don't belong to this particular tooth or this particular patient. Okay, because there's something not right. This is not somebody else's case. This is my own case. We all have our failures, and the failures are what which help us learn more. Okay, with this, let me take you to a layering concept, what we call as a biological layering concept with MICD. No, how is a why do we call it a biological layering concept? Because it follows the biology of the natural teeth. This is what we are going to create, okay, with our layering recipes. Let's see how. The palatally, how we have the natural tooth, enamel layer. Then what we have is a deep dentine layer or an opacious dentine or an opaque dentine. Why we want an opaque dentine in a situation like this, in a class 4 restoration? Because we do not want light to pass through and through. We want something to block the light, so that it does not appear as we had a failure case. Okay, we just saw just now. So we need to block the light. So we have an opacious or a deep dentine layer. Then what we have is a body dentine layer. Now see where this body dentine layer extends. This body dentine layer has to extend on the natural tooth surface. Why? Because we want to block the transition lines. We do not want to see that class 4 restoration or the build-up looking separate from the rest of the tooth. That's the reason we have to give short bevels on the adjacent natural tooth so as to mask the transitional lines. Then what we have is the effects layer. Now, effects layer is where we want to create effects like cracks, or we want to create like hypocalcified areas, or some brown stains, okay, and white stains for the halo. All this is done over the dentine layer, and which is followed by the enamel layer. Now, you see where this enamel layer is extending. It is extending even beyond the dentine layer on the natural tooth. So, for the enamel layer to extend, we need a long bevel or an infinity bevel. So this is what our layering recipe is, so as we get restorations which are biologically layered and which are biologically aesthetically more acceptable. Let's look at the situation. A similar situation what we had in the earlier case. Now to follow up this particular case or this situation, I need to first do my homework. My homework would be what is the shade I'm going to pick up for this particular situation. So it's not just one shade, it's multitude of shades because I'm looking at deep dentin, I'm looking at enamel, I'm looking at body dentin. So I am gonna pick up the shades. So what I do is first I I take an image, I reduce the exposure in that image. I can go to my phone. We all know how to reduce the exposure in an image. I reduce the brightness. When I reduce the brightness, I am actually able to see through the tooth. I'm able to see the layers. Okay, where I would need, if you see the incisor part appears a lot more translucent. That means it has lesser dentin or enamel. Enamel is more translucent compared to dentin. And that's how the modern composites, what I'm going to introduce you to, okay, will be reflecting or they will be describing to the properties of natural dentin and natural enamel. Okay, next what we do is we pick up the right shades. We saw the layers, now we want to pick up the right shades. So I introduce you to a technique called composite button technique. So what we do here is we take body dentin or the body shades or the dentin shades. Where is body and the dentin shade more in a tooth? Cervical areas and the middle thirds. So what we do is we place those buttons in the middle thirds or in the cervical thirds. And when we take up the closest enamel shade and that we place up in the incisor area or between the incisor and the middle areas. Now we move on to select the shade by altering the image. First, we want to pick up dentin shades. Dentin is what? More. It gives us the shade of chroma. Okay. So we oversaturate the image, and whatever shade blends, we pick that up as our dentin shade. Similarly, what we do is then we desaturate the image, as in convert that image to black and white, and see whatever shade blends that we pick up as our enamel shade. Okay, so we picked up our body shade, we picked up our enamel shade, and then we'll go back with our layering. So we had done a mock-up. So we do a palatal index, so that gives us more control. So palatally we create a palatal wall or the palatal on which we are going to layer, and we do a body shade layering. And over that, this is our layering protocol. What we discussed, we are going to follow that protocol. And on the body shade, okay, what we do is the stain layer. So we create that white stain with the white tint or the white light art color. And with finishing and polishing, this is what we are able to achieve. Does it look blended? See, there are no transition lines. It looks like the part of that particular tooth. Looks like belongs to the same patient. Looks similar to the adjacent tooth. Okay. So yes, following the right layering protocol and following the right shade recipe, we are able to achieve results like this. Let me tell you some interesting facts in aesthetic dentistry. Human eye is more sensitive to value, that is brightness, than minor differences in hue or color. And in most of the cases where value and chroma are right, our restorations are aesthetically acceptable. See, these are two most promising points when we look at shade selection in dentistry. Another, make a picture of this slide. This is going to change your life. This is the order in which we look at the aspects in aesthetic dentistry. value, translucency, shape or anatomy, texture, chroma, and hue. Hue comes the last, right? And what we have been doing all these years with our beta classical shade guide is we have been looking at hue first. We pick up segment of A shades or segment of B shades or C shades, which should be done the last. We have to look at value first. We have to match the value. That's the reason the modern shade guides or the newer shade guides, they are based on value. So this is Vita 3D Shading 3D Master. This is a value-based shade guide. So if you convert it to black and white, you are actually able to see the, the lightness to the darkness. If you don't have this shade guide, or if we are using this particular shade guide as a Vita Classical, now you see this shade guide, how difficult it is to assess or determine the shade. Looking at the shade guide, it's so confusing. Where do I start from? A simple thing which is going to change our life, or it will change my life, or it's going to change your life, would be converting this Vita Classical shade guide, which is hue and chroma based, to a value based shade guide. Okay, take a picture of this slide, go home, go to the clinic, and arrange your shade guide in this manner. Or otherwise, just Google value based arrangement of Vita Classical shade guide, and you're gonna get this. Now, see how easy it becomes to determine the shade, how easy it becomes to read the shade. Because I'm gonna go brightness wise. Okay, I'm gonna make your life more beautiful by introducing you to another concept or another what we call as the material science, what we call as biosmart composites. These biosmart composites from Shofu with the shades, okay, multitude of shades from opacious to body to the mid opacious to the enamel shades. This composite system will transform your bonding dentistry or the direct restorative dentistry to another level. See, there are certain attributes. Okay, what I have noticed here is the dentine shades and the body shades, they ascribe to beta shades. So I don't have to train my eyes to multiple shade guides. One shade guide does my purpose for the directs as well as indirects. And again, in two different shade guides, the A2 is not going to be the same. So it's always better for me to train myself to one shade guide. So many times, okay, I don't even look at the shade guide. I look at the tooth. I know, I'm gonna pick up an A2 shade or an A3 body shade because I have trained my eyes only to one particular shade guide. The enamel shades, they are based on value. Okay, see, generally what we see is the composite systems with the shade tabs, as in the the composite shades as dentine A1, dentine B2, dentine C, dentine B, D, and enamel A, enamel B, enamel C, enamel A2, enamel A3. It's so confusing. What if I have my enamel shades give me the idea just on the brightness? So what I have is high value translucent, translucent, low value translucent, and amber. Means this is translucent and it is going to increase the brightness. This is going to maintain the brightness. LVT as a low value means it is going to reduce the brightness, and AM means if I want to add a little yellow, for example, aged dentition. Okay, where the geriatric patients, okay, where the teeth are more yellow. Okay, therein I can pick up the enamel shade which has more amber shade, which has more yellowness in it. Okay. Then the natural fluorescence and opalescence properties of this particular system, and the minimal shade after photocuring. That again is a very important aspect. So many times, okay, we see, okay, we bond a veneer. Okay, before we do a dry fit check, everything looks perfect. The moment we bond the veneer, indirect veneer, God knows what happened, and the shade completely changes. Does this happen to anybody? It has happened to me so many times, almost every time. Because composites, they change shade once they are photochemical. So these composites, the shade change is minimal after the photocure. With these new dimensions in mind, let us look at this particular. I am going to show you some clinical situations, how we manage them. Okay, with this fundamentals of color science and the composite system and the biological layering concept. Again, a similar situation. I'm coming back to the same situation again and again because this is one of the most difficult situations we encounter in our everyday industry. Restoring a single central incisor. If two lateral incisors have a different shade, it is manageable. Okay, many times we do that deliberately so as to create more, creativity, to create more, naturalness. But two central incisors, if they have a disparity, you are gone. They have to be mirror images of each other. So that's the reason I'm coming back to the most difficult situation again and again, again and again. So let's look at this particular situation. So what we do here is again we're going to do color mapping, but I am going to change my concept of shade taking now because with the I'm not forward with the understanding that I have to look at value first. Okay, so what I'm going to do is I'm taking the closest possible shade down and that's which is going to decide my layering protocol. So my homework is lesser. So what I do is that's the closest shade tab. So this is my layering protocol. Bilaterally, I'm going to use incisal or a universal enamel because that's how the biologically it is. Then I have to use an opaque denting because my shade is A3. I'm picking up a A3O and I'm picking up my body shade as the A3. Okay, so I am just selecting my body shades here as of now. I am unsure about what enamel shade I am going to use. Okay, so I leave it. And I do not, I don't leave it, I don't decide it. Okay, so I do my homework. Okay, I always prefer to do my homework in situations like this. See the anatomy. The tooth is rotated. Okay, so I do a mock-up and I do a body index. This gives me a lot of control. So I go with my that injectable, okay, a translucent injectable as in INC shade, okay, and we go ahead and create the palatal shell. Similarly, okay, we create the mesial and the distal shell of the proximal walls, okay, with the transparent as in T enamel, that is transparent enamel, okay, A3 O dentin and body dentin and now I see what is my tooth appearing in terms of when I compare it to the adjacent one. Now, when I compare to the adjacent one, I feel okay, I need to add a little grayness. Now, enamel shades are gray, they add more grayness. Dentine shades, they are more yellow. So the yellow is chroma. So they add more yellowness. So I want to subdue this yellowness by grayness. So I pick up a T enamel, as in transparent enamel or a translucent enamel. Go ahead with the finishing and the polishing protocols. Okay, so that's we have the with the MICD. Okay, the process or the steps to be followed in direct restoration with the polishing protocol. Okay, we follow those polishing protocols, and this is what we are able to achieve. Does this look blended? Looks quite close to the adjacent one. Checklist. Look at the value. Translucency, shape and anatomy, texture, chroma, and hue. almost everything balanced. And that's what we have been trying to achieve in this particular situation. Now, for example, you want to treat this case not as a minimally invasive case, but you wanted to do a crown on this particular situation. In fact, this patient was referred to me by another of our patient because now this patient was advised, this patient had been to some other practice and he had been advised a crown on that particular tooth because dentist wanted to do a crown on that particular tooth. And so he said, that tooth needs to be root canal because I'll have to prep more. So an endodontics followed by a crown. Because he will not be able to match the shade with the adjacent one, this patient was advised a crown on the adjacent central incisor also. And see, because that's a simple way to proceed. This requires a lot more finesse, a lot more skill. And skill is not difficult to develop. All we require is a bit of dedication. And we are able to develop that skill and offer these minimally invasive protocols to our patient. As Dr. Ronnie and Dr. Soni rightly said, practice no harm dentistry. Okay, so that's what we follow, minimal. We need to reduce the biologic cost for our patients. What I would prefer in my mouth, I would anytime prefer this than a root canal and 2 crowns on the 2 central incisors. Let's look at another situation, complex situation. Why? Because look at the problem list. The anatomy, diastema, proportion, the shades are not coherent, and the discoloration. Let me do my homework. Okay, so that's my homework. I sort my anatomy, I plan this is what I want to do. I want to reduce the distal of the centrals, increase the width of the laterals on the mesial, close the diastema, taking care of the proportion with this. Okay, so half of my problem list. Okay, I plan this way. Let's come to shade. What shade do I pick up? The closest to this one is A2, to the next one is A3. How do I proceed? See, it's not a level playing ground. I need to have a level playing ground. So, what do I do is prep, isolate, create the palatal shell. Okay. Now, let's create the level playing field. I do not have sufficient space here to add opaque dentin. Okay, because opaque dentin to be efficacious, okay, it would require some thickness. So what I go ahead and do is use an opaque. This is like a paint. As I use this opaque, this is what we get. I have a level playing field on both these teeth. Now I can select my body shade and I can select the further layering protocol. Okay, so I go ahead and pick up A2 as the body shade, layer up. Then I see, okay, how I, this after doing my body shade, how it matches with the adjacents. Okay, whether I need to boost up the value or I need to reduce the value or I just need to add a little grayness. Okay, so I pick up my enamel shade and that's where we are. Problem list, kind of all sorted. That's what we are able to give to this patient in a very, very minimally invasive way. Look at this situation. Is it simple or complex? See, had it been an aged individual, it would have been a very simple situation. Young individual, see the translucency, and see small amount of chip. Smaller the chip, bigger is the problem. It's more difficult to restore. Because it's very difficult to work in a very teeny mini space, in a very small space. Let's see how we manage this situation. The situation is complex, but I'm going to give you a very simple solution. Again, shade taking by visual perception. I pick up the closest beta shade. With that shade, I take my composite. Okay, I do a mock-up, so it gives me an idea of the anatomy. I'm able to get the occlusion so that I don't have to reduce occlusion later. Do a putty index. Okay, now I start. Bevels, short bevel and a long bevel, right? That's what we look at to, blend, so that we do not have those interfaces, we do not have those transition lines. Okay, so we create. If you can see these images, you'll be able to see very clearly. Okay, the short bevel as well as the long bevel. Now, I'm going to use a single shade in this aesthetically, or I would say highly aesthetically demanding situation of a young individual where we see so much of translucency. But how on earth I'm going to manage with a single shade? I require a biological layering protocol here. But in such a small space, at times it becomes really difficult to give us, to follow that, protocol. So we do the same thing, but we just modify the protocol. Okay, how we modify the protocol is, I'm again creating the palatal index or the palatal shell. Once the palatal shell is ready, okay, I layer it with again, this injectable composite. Okay, my first layer of injectable composite is there. Okay, on that. With that, I create some mamelon effect. Okay, and then I go and pick up a color or a blue tint. Blue tint is to give the effect of the enamel. So I add in that blue tint there. Which layer you added? Added over the dentine layer. Okay, so I've already created my dentine layer. Over that, again, I relayer with the same. These composites are so easy to use, these injectable composites, especially this injectable X, because see, it is like, once you place it on the tooth, okay, you wait half a day, but the composite will not move from there. It's so stable there. Okay, so you just take your very fine explorer, okay, and just tease it onto the bevels you have created. Another one, okay, what we use here is injectable SL, which is self-leveling. Okay, that works, even wonderfully because it spreads very slowly. So once you start using these, you get an idea of where to use what. Okay, so I layer that base shade over the tints and back again, okay, with the same shade composite, photo cure, and always after photo cure, okay, we put a glycerin jelly, or we want to remove the oxygen inhibition layer. Okay, so we photo the glycerin jelly and follow the finishing and the polishing protocols, and this is where we are. Can you believe this is a single shade composite? Just a little alteration in the technique. Let's look at the blend. Okay, there are no transition lines. Okay, the translucency effect we are able to achieve, and see the value check. Always see. Somebody in the morning, he told me, or in fact reminded me, uh, the winner of our MICD challenge, camera is my best critic. Yes, so when you document, you are able to see the flaws. So that's what we are able to achieve, and this case was published recently in Dental Asia. So look at another situation. How do we manage this situation? But if I were to tell you, this is already a managed situation. I don't have to do anything for the management. This situation was actually like this. So we did a diastema closure in that particular situation. See the complexity level, see the shade of the teeth, gradation, striations. Somewhere there is more chroma, somewhere there is more value. Again, to remind you, chroma means the yellowness or the darkness. Whiteness ascribes to the value. Okay. So what do? Again, we do a visual perception as well as a composite button technique. Okay, to narrow down on the shades. Okay. So again, a mock-up really helps to pick up the right shade, plus helps you develop the anatomy, gives you a little bit of practice, and it does not take more than 5-7 minutes to do this kind of a mock-up. Do a palatal index, that makes your life so easy, and isolate, and again follow the same protocols, bevels, because we do not want any transition lines, and minimally invasive work. Okay, we create the palatal shell, because we have done our mock-up. It becomes very easy for us, okay, to dimension wise create where we want the midline and how much we need to add on each particular tooth. And we go on, put on our body shades. So we are using the posterior matrices here to form the proximal walls. And once we have done the body shade layering, now we want to create the effects. What is the effect needed in this situation? White striations, hypoplastic areas. Okay, so what we do is we pick up the light dark white stain, and where we have the striations, I go with a very thin explorer, okay, and create those white striations. But in the incisal areas, there are lesser striations, more of cloudy white. So with my micro brush, I create that cloudy effect, layer it with my high value translucent now. Because once I did this by body shade layering, I felt I want to boost up the value, boost up the brightness, more value to that tooth. Does not mean more money coming, but yes, value is increasing the brightness, but that's increasing the increasing the brightness or increasing the value does get you more money. Do whitenings. So on both those, okay, we add the HBT layer, the high value translucent, and this is what we are able to achieve. Still, we have to go ahead with finishing and polishing protocols. So after we are done with finishing and polishing, this is what we are able to get. See the vividness, see there are no transition lines, see the translucency effect in the incisal portions. Okay. And let's do a value check. No difference with the adjacent to structure. So the value match is perfect. That's what we are looking at, doing a value match. My last case, okay, let's look at this situation. How do we pick up the shade here? Now, before we pick up the shade for these non-carious cervical lesions, let's look at what will happen if we do our routine restorations there. These teeth will become enormously long. They will start looking at it like a horse's tooth, won't it? Is there any other alternative? Yes, a mucogingival surgery, a gum graft, and I love to do those surgeries. But certain patients, they are not receptive to those kind of surgeries, or at times they're patients who are medically compromised. So what do we do here? That's another resource what we have. Another differently colored composites. That is pink composites or gingival composites. Okay. With again the variety of shades, and you can still get more variety of shades by blending them. So that's what we do. We layer it up. Isolation, the rubber dam isolation was difficult in these situations. In these kind of restorations, I would prefer, with using Teflon as a retraction cord. So I package some Teflon in these sulcus areas, and I layer it with different uh, composite, big composite shades, doing some blendings. That's the reason you can see some different shades here and there. with any kind of cervical restoration, the finishing and polishing has to be up to the mark, as in it has to be more than 100%. We cannot afford to leave any kind of overhangs inside. Okay, so thin finishing, okay, goes all the way into the surface, and again finishing and polishing, and that's what we are able to achieve. How long is this is going to last? I don't know, but see, I have a 2.5 year record for this particular situation. Still same as it was on day one. See the tissue health looks impeccable because we have followed the right finishing polishing protocols and allowed no gingival accumulation. The patient has been following good hygiene. I throw another question at you. Which one is darker, A or B? Anyone? Which is darker, A or B? Actually, both are same. So this is a color paradox. Color is relative. Similarly, if you see in this situation, the two middle squares, they are the same color, but they will appear different to you. Here, the counters on the upper and the lower, they are the same shade, same color, but they will appear different to you. Why? Because shade is relative, or shade would be subjective. And these are the parameters which may affect the shade taking or the shade assessment, operator judgment, operatory lighting. If you have yellow lighting in the operatory, it is going to obscure your shade. So try to keep your lighting in the operatory similar to the natural light. Distance, ideally your distance should be about 2 to 3 feet, okay, for the shade assessment. Hydration of the tooth. If you dehydrate the tooth, as in, okay, you put in a rubber dam there, okay, the tooth is dehydrated, you are not going to get the right shade. Because dehydrated tooth appears more white, it will always give you a more desiccated look. So you have to always take your shade before you put in the rubber dam or do the isolation. And the environment and the backgrounds. Ask your patient to remove those dark red lipsticks before you do the shade assessment, because it may change your shade perception. With this, I would like to conclude with these pointers that while selecting the shade, you should be looking first at the value, then at the chroma, and lastly at the hue. Shade taking should be done before the rubber dam or any kind of isolation. Proper bevels should be given, okay, so as to get the right blending. And biological layering concept is going to make your life actually beautiful. And use tension colors wherever needed, okay, to get that extra effect and the extra characterizations. And this, thank you so very much. And any questions, you can address me on my mail, or you can follow me on my Facebook handle. Thank you so very much.
Thank you so much, Dr. Amit. Thank you for bringing us to the colorful world of dentistry. Truly, the cases you shared are valuable,
Thank you so much.
and your checklist will definitely be noted.
Thank you.
I wish we had more time for questions, but I'm sure our dear Dr. Amit will be open to your questions later, maybe at lunch and during the tea break. Thank you so much again. We would like to call in our dear chairman of Shofu Asia Pacific to award the certificate for our lecturer. On stage, we have Sir Patrick Look to award the certificate to Dr. Amit Gulati.
Thank you so much. Thank you.